Uh, so good afternoon, everybody. This is the first webinar of the fungal sepsis training program. And this webinar will be related to the first module, the module 1, that is related to understand the basics. My name is Pedro Pova. I'm from Lisbon, Portugal, and I have the privilege to co-direct this course with my friend Marlies Osterman. Marlies, please introduce yourself.
And I'm Marlies Osterman. I know my name is displayed as Martin Hunger, but I apologize for that. So I'm Marlies Osterman, and I am a consultant in critical care and nephrology at Guy's and St. Thomas's Hospital in London. And I'm very honored to co-chair this great program, which is very educational and has taught me a lot in the last few months. So I very much look forward to a discussion with the experts today.
And now I'm going to share the slides with you. So okay, are you seeing the slides? Sorry, because I'm a little bit. Are you seeing the slides or not?
Yes, we do. Thank you.
Okay, so because this is a little bit strange how it appears in my computer. So this is the fungal sepsis training program. Is a program that is run by the society after an unrestricted grant from Gilead. And so the overview of the program is the target population is the members of the society, residents, fellows, and other ICU specialists that want to improve the knowledge and the skills in the area of fungal sepsis. And we will have 6 modules. The first one that we are going to have the first live webinar today is on the basics of fungal sepsis. And in all modules, you have online content and then the live webinar. The second module is on antifungals from the drug to the therapy. The third mainly on invasive aspergillosis in different patient populations. The fourth, challenges in fungal infections, diagnostic specific patients therapy of mucor. The fifth would be on fungal sepsis and septic shock, an integrated approach. And the last one are virtual reality experiences on Aspergillus and mucor, and also on Candida. And this has been done recently in Paris, and the production of these virtual reality experience videos are still on production. So the evaluation of these courses, excellent courses there's a pre and post test with self-assessment, with the satisfaction questionnaire that we want from you. And also it has certificates and also credits, 20 CME credits. As we have already presented ourselves, so I have the privilege to co-chair this course with Marlies Osterman, and we also have the input of our current president, Elias Aleid, that is also one of the directors of this course. That has a large list of experts. In total, there are 30 experts from 14 different countries that produce a total of 55 video capsules, so a huge amount of work. And we will have 5 live webinars. This is the first one. Please put in your agenda the next ones, the additional 4 live webinars that will take place more or less, not every month, a little bit more than every month. But again, take note on these. And this has been till now quite successful. We had more than 650 registrations, and so that this means the interest of these very nice educational program with excellent presentations. And now I'll give the floor to Marlies. Marlies, please.
Thank you very much. It is a great honor to have the experts here who provided fantastic overviews. And as Pedro already said, in this webinar today, we will focus on the essentially basic physiology related to fungal infections and the physiology related to host response. So why do some patients develop a fungal infection, and why does the host develop resistance? And just to remind the audience, we have amazing lectures available online which summarize all these pathophysiological processes and our current thinking. In summary, the experts available on this call now provided summaries that highlight the fact that fungal infections essentially are an evolving process at the moment. So the taxonomy and the nomenclature is changing as we are learning more. Clearly, in the last few years, we've particularly learned as a result of advances in molecular techniques and the ability to diagnose fungal infections better. But ultimately, fungi invade the organism, mainly through the skin and the mucosa. And then we have a very dynamic, complex interaction between the fungus and the host. Numerous cells play a role, but in particular the antigen-presenting cells and the macrophages. And they, as was elegantly demonstrated in this lecture online, they sense the parts of the architecture of the fungal cell wall and subsequently elicit very crucial immune responses. Now, obviously, this is a dynamic and complex problem. So along the way, host medical problems, immune deficits may increase the risk of fungal infection and fungal invasion. That's really related to the main pathophysiology. And then we had a lecture series related to the development of host resistance, which essentially was summarized here. And Pedro, do you want to just summarize the talks? You're currently on mute, Pedro.
So concerning the mechanism of host response, what is also interesting is how the fungal cell wall interacts with the immune, our innate immunity, and how also in some situations it seems that they can go along together very well, and sometimes they will develop an infection. And the activation of our immunity, it is very important, the activation of the C-type lectin receptors for having the response against the fungi. And we have, it is important to have both cellular and humoral innate response to have our protection against the fungi. So this is let's say a combined work between our immunity. And the innate immune receptors and molecules play a major role in this complex susceptibility to fungal infection and response also to fungal treatment. So there is everything. This is a complex work. And we also have important lectures on how COVID or SARS-CoV infection, so the COVID-19 infection could change these immunological response that would increase our susceptibility to invasive aspergillosis and also to increase susceptibility to mucor infection, particularly in India, that could also be related to some of the therapies that has been administered to these patients.
So this is the summary of the great lectures which are available online and which you will have listened to. We have the experts, the international experts who gave these presentations here with us today. And they are available to answer questions related to their previous talks. But obviously, they will also now comment on some cases which we've prepared.
And now I think what we can do is to ask the experts that are present today just to present themselves. For no or the order could be the order. I think the program may be Gary Falia. Can you just present yourself?
Hello, everybody. I would like to welcome our guests. I'm very, very honored to participate in this very innovative educational program. And I'm very happy to answer questions if there are relating to my presentation. I work with intensivists for several years. I'm an ID physician and associate professor of infectious diseases in Athens National and Kapodistrian University. And my general research interests are focused on nosocomial infections, multi-drug-resistant infections, and infections in critically ill patients. Thank you very much.
Thank you, Gary Falia. Sarah, can you present yourself, please?
Hello to everyone. I'm also really happy to be joining this this program on invasive fungal disease. I'm an assistant professor in medical mycology, working at Saint-Louis Hospital in Paris and doing basic research on aspergillosis at the Pasteur Institute.
And finally, Martin.
Hi, everyone. Thanks, Pedro. Let me undo it. I'm currently sick in bed, so I hope my voice will kind of like last through the webinar. My name is Martin Höniger. I'm Associate Professor for Translational Mycology at the Medical University of Graz from the infectious disease side. So I'm part of the division of infectious diseases there. And also super happy to answer questions and also present some cases later on.
So thank you very much. So as you can see, this is a unique panel of experts, and so you have opportunity to ask and discuss whatever you want with them. This is a very important opportunity also to learn and to take any doubts. And so what I would also ask you is to use the chat to make the questions, whatever you want. That we are myself and Marlies, we are monitoring the chat to see the questions that would appear. And what I would now ask you, after having went through the videos of the module 1, is if you have any burning questions that you want to start to ask to the panel, to this experts panel. And you can just start writing whatever you think important or doubts that you want or things that you want to be clarified from the lectures. Please go ahead with that. and we'll wait here. If not, we can also start discussing some clinical cases. It's a little bit up to you, but if you have any questions, comments that you would like to address to the experts.
Sounds good. I mean, Pedro, questions may come up as we go through the cases, and we would like to invite the audience to add questions later if they come up throughout the discussion. So it's really the whole idea is for us to intensify through real cases what was demonstrated and outlined very elegantly in the online lectures by international experts. And we want to create the link between the bedside and the teaching sessions. And today's today's webinar should really focus on the pathophysiological processes behind the clinical developments as we see them at the bedside. I can't see any questions from the audience at the moment, so maybe we just start with a case, and again, I will invite the experts to comment on this as we go along, but also the audience to ask questions. Okay, so
there's one question in the chat that appeared, at least for me, that I would start with I think could be, I don't know which one of you would like to answer. So why Candida is so prone to make biofilms and to set up lesions in valves, in heart valves and retina? Any who would like to address this issue? Martin, Garifalia, or Sarah?
Well, if you would like me to start first.
Yeah.
It is part of the pathophysiology of Candida to interact with the host and sometimes with other bacteria of the microbiome and make some synergistic movements, and in that way it creates the biofilm and it is embedded in the biofilm. It is one of the basic characteristics of fungi, which we are able to detect in the recent years. We didn't know in the previous decades their ability to form biofilms and their particular characteristics within the biofilm. And now that we know that we can explain recurrence, persistence, and antifungal resistance.
And is it because of that also sticks in the heart valves? Is it the same mechanism?
The same mechanism applies to the heart valves, and in the heart valves, there are high numbers of pathogens, and once these numbers of pathogens are embedded in the biofilm, it is almost impossible to eradicate with antibacterial treatment, antifungal treatment. All the infections that have to do with heart valves are infections that have abundant numbers of microbes or fungi. The bacterial load.
Martin, I think we would like also to add something. Martin?
No, I think, it just highlights, what we just heard highlights the, our reason for example, removing the, foreign devices or central venous catheters, for example, in patients, or changing them if anyhow possible. Because of course we have also the problem there in patients with candidemia that they form biofilms on these central venous catheters. I mean, of course, there's some discussion of, what to do if it's not easily possible to change, and most patients need their CVCs in the ICU, right? So that's always something that has to be decided on an individual basis. But in principle, if anyhow possible, the CVCs should be changed or removed. Yeah, I think that's just important to emphasize, because this falls in the same. And then in terms of endocarditis, and there's also some discussion how often this occurs in patients with candidemia. But most estimates estimate about 10%, maybe a little bit lower than that, of patients with candidemia would develop at one point some involvement of the heart. Sometimes it's 5%, a little bit lower.
And is it the same with all Candida species, or are there some that are more prone to make endocarditis?
That's maybe something I will forward to a Candida specialist. I mean, I don't know if there's...
I don't know. I just raised this point.
If I may add something. So actually the pathophysiology of these species making biofilm is actually their ability to secrete some very sticky polysaccharide that are also made in their cell wall, but they can secrete it in the extracellular matrix. I mean, Aspergillus can do it, and it's a well-known polysaccharide named galactosaminogalactan. Pseudomonas aeruginosa as its own well-known polysaccharide, which is named PELA. And there is strain that, even among the same species, there's strain that can produce more or less of these super sticky polysaccharides, and then their ability of producing biofilm may change. So even inside the same species, you can have different strains with different ability to produce biofilm. So of course, among different Candida species, you can also find different ability to find biofilm, but we lack like deeper clinical data on this.
Great. There's a question in the chat also, is from Lucas. Thank you, Lucas. So how, in this context, how can Candida cross the blood-brain barrier or brain-eye barrier? So how does it work that? How does it do that? Is that a question, or answer to this question?
I mean, I can just start off with, giving some stupid response, and then there may be some better responses later on. But obviously, when you think about Candida brain infections, usually they occur in patients that have, some devices or catheters already in place, right? So that are patients where the blood-brain barrier per se is not intact, and then via, these extraventricular devices, for example, these blood-brain, these brain infections occur. So that's, at least in my clinical experience, the vast, if not the whole experience with CNS Candida infections. These were the infections I was seeing. But there may be others, I mean, in very few. I mean, Candida blood-eye barrier is something different, of course. And maybe there are some basic scientists who can explain us more, because eye involvement in Candida infections does occur pretty often. I mean, in candidemia, we are again talking about maybe 5%. It's not all endophthalmitis, it's often keratitis as well. But it's 5 to 10% again of eye involvement in candidemia. That's why we usually still agree that we should call the ophthalmologist on candidemia patients to examine for that. So that's definitely a bigger issue, but the brain infection, or meningitis or encephalitis is very rare, in my opinion.
Okay, so maybe this is an excellent starting point for this clinical case. So Marlies, can you go through it?
Yeah, sure. So it's a great honor to share a case with you. It's a real case of a patient who is currently still in the intensive care unit, but the person puzzled us a little bit, and the question really is, why did this particular person develop an invasive fungal infection? And I will present it as I experienced it at the bedside, and I would really like the view of our international experts here with regards to the background, presumed background pathophysiology. So you elegantly described it in your lectures, and I wondered, once I go through it, whether you could hypothesize why this person developed a serious infection. So the person we're talking about is a 43-year-old male who is non-white and suffers from sickle cell disease, a genetic disorder, but this was not giving him any trouble until this current admission. He'd never had a blood transfusion, he was not on any medication, and the only medication he was on were inhalers for asthma. And apart from that, he lived a very healthy lifestyle. And the person got admitted after he had presented and been seen in the hematology clinic for a routine checkup. And at that time, he complained of some general body pain and said that he had COVID. The COVID infection wasn't really a problem. It was just had tested positive, but it was the severe body pain which made him go to the hematology clinic and pass this on. The team who saw him was quite concerned about the amount of pain and felt that he needed to be admitted for some intravenous pain relief. On admission, as you can see here, CRP was only 12, his white cell count was raised, his hemoglobin was a bit lower than normal, and he had evidence of some hemolysis. His LDH was up and his liver enzymes were elevated. And initially he was admitted to the hematology ward, but it was very difficult for him because there was increasing pain, which couldn't be controlled with the standard analgesia as it could be provided on a normal ward. And he increasingly felt breathless. So after the first 24 hours, he got admitted to the intensive care unit, again, with a view to treat his pain better, and also with a plan already to do an exchange transfusion. He received oxygen, he received more fluids to ease the sickle cell crisis, and a unit of blood. But within the first 24 hours in the intensive care unit, things got worse. He got much more breathless. He was intermittently hypoxic. When he was hypoxic, he was disoriented. And it was clear that the situation was not well controlled. And to get better controlled, he got intubated and connected to mechanical ventilation. Sadly, things continued to deteriorate. And within the first 24 hours, he needed more oxygen whilst on mechanical ventilation. His kidney function deteriorated. He had he had a fever, and the concern was that there may be an additional bacterial infection as well on top of the pre-existing COVID and the sickle cell crisis. So the exchange transfusion was started, broad spectrum antibiotics were commenced, and the dexamethasone and remdesivir, which had been started before, were continued. Because he had very high oxygen requirements, a CT was done, and it just was consistent with a right basal consolidation suggesting a possible bacterial infection. This prompted a bronchoscopy, and the bronchoscopy was relatively non-specific, showed some basal secretions, but nothing else which made clinicians concerned. He had daily plasma exchange, exchange transfusions or plasma exchange transfusions, but remained intermittently febrile. And then on day 6, we were informed by the microbiology team that his blood cultures were positive and had shown some yeasts. At that time, the sputum sample taken during the bronchoscopy had also shown Candida albicans, so it was assumed that the blood cultures were Candida albicans, and this was subsequently confirmed. So he had a candidemia as a result of Candida albicans infection in the bloodstream and in the chest. And based on the advice from our microbiology colleagues, he was commenced on anidulafungin. We followed all the recommendations of current guidelines, changed.
Marlins, can we stop in the previous slide and we discuss, because there are questions, some questions related to the case that I think are quite relevant.
Sure.
One is if the blood cultures were taken before or after the blood exchange. Do you have that information? Yeah.
They were taken after the first day of exchange transfusion.
Okay. And one of the things that we can here discuss with the expert is the value of Candida identification in these different samples. I think that could be quite relevant to discuss this. So what do you think could be the meaning of Candida in the sputum and in the blood? Are they equally important for you? What do you think? Well, can you make some comments on that?
I refer to our international infection colleagues, so
Yes.
it's either Sarah or Gavilia.
Sarah,
Yes,
yeah.
I'm sorry, Petra, can you repeat the question? There was some people
Sorry,
through my office and I couldn't listen properly.
The question is, at day 6, these identifications of Candida albicans in different samples, how can we value these, if you value equally in terms of infection, how to value these identification in these different samples?
How to value this identification? I mean, whenever a Candida albicans is growing, if that's the question, is growing on a blood culture, I mean, there's no question.
No, but in sputum.
Oh, in sputum. Oh, of course. Oh, then you disregard. I mean, 50% of patients in the ICU are colonized by Candida species, and we really do not care about these samples anymore. I mean, there's a lot of papers from the late 2020s, and it's no, any respiratory sample with Candida species are not to be.
Okay, I think that's a very
important. Also from my side, fully agree with Sarah. Actually, I mean, I think the sputum does not tell us a lot. Of course, if we have blood culture result yeasts, this will make us assume it's Candida because it's just most frequent, right? It could be other rare yeasts, it could be other pathogens, but just the fact that yeast will kind of like prompt us to initiate treatment right away. So we would not wait for anything more if we have a blood culture positive in this patient and administer right away, but most likely an echinocandin in most institutions around Europe, and waiting the identification of the actual yeast and whether it is Candida or another rare yeast. But I totally agree with Sarah. The Candida albicans in the sputum sample does not add any information here, because even independently, I mean, there's some discussion, but the problem is that nearly everyone in the ICU at some point develops colonization of the respiratory tract and does have Candida in the respiratory tract. In a bigger picture, it may even be some kind of a bad prognostic factor, but that might have to do that these patients sometimes are for a longer time in the ICU who develop that. So it's just in terms of clinical diagnosis of Candida infections, it's very rarely relevant, although there may be very, very few cases of Candida pneumonia, but for those we need some radiologic findings and some histology to really prove that, and just the sputum or the BAL with Candida detection is really not sufficient because we find that in nearly everyone.
But Martin, do you think it was correct that we made the assumption that this yeast, because it was Candida albicans?
I would just make I think it was absolutely correct that you assumed that this was Candida because Candida is so much more frequent than these rare yeast infections, right? So just by likelihood, it's most likely that it's Candida. So that's why I would initiate a treatment for Candida, which would be echinocandin. I mean, depending on your institution, it may be albicans, it may be something else, right? Usually we are dealing with about 50% or less albicans, but in some institutions it's still more than that. So it could be some others, but it doesn't matter. For initial treatment, it will always be an echinocandin. I would not dare to start at, if I want to start at this point, I just have yeast, I wouldn't start with a fluconazole, for example. I would definitely use an echinocandin because of broader activity, because we don't know anything more particular. So that's, I think, it's absolutely correct here to assume it's candida and start right away. And, acknowledging that you may later adapt your treatment depending on the identification of the pathogen.
I was also going to ask you about the azoles. Do you think is it on the difference is only spectral, or is also in being a cidal or static, fungicidal or fungistatic, in terms of what do you think? Does it make a difference, or is it the difference in spectrum?
I mean, one thing we're discussing about echinocandins is, of course, I mean, that's a big thing for me, are the activity against biofilms, right? And especially when thinking about the endocarditis, which is a complication which is terrible, as we heard before, and really can only be solved by surgery or often lifelong treatment. This is something, the biofilm activity is a big plus for me as well, to use an echinocandin, apart from spectrum. I mean, this cidal versus it all depends also. There's so many things that go into that. It depends on dosages. It would not be my major driver. I think my major driver here are, first the guidelines, because they're very clear on that. Then, of course, the reasoning behind them, which is the spectrum, which is the biofilm activity, and which is also the tolerability, right? I mean, that's the other part. Drug interactions tolerability is another part, why to better. But I think here in this particular case, where we only have yeasts and no further identification of the pathogen, I think the spectrum, if I have to decide for one, the spectrum is the number one decision for me here, to definitely use an echinocandin, even if I otherwise rarely use an echinocandin in my particular institutional setting.
There are two questions in the chat, one from Melinte that asked if the candida in the respiratory tract was a sputum or a tracheal aspirate. Can you clarify that, please?
Sure. It was initially just a tracheal aspirate, but also then subsequently shown on one of the bronchoscopy samples.
And for the expert, does this make a difference? I can start with Sarah, that was addressing that issue before. Does it make a difference for your comment?
No, to me, it doesn't change anything, whatever the sample, whatever the respiratory sample.
Okay, and the next question is concerning the blood cultures. I think we addressed already that we have to value the result of the blood culture. I also at this point would like to have a question to all of the experts, because this is the module 1 on the basics. And the question is, in this patient, why do you think he had this infection at this stage? What make his, let's say, this interaction between the candidates and the immune system end up in this invasive candida or candidemia? Where was the defect, let's say, or if there is any defect?
I mean, like in my opinion, in here, the patient was actually, so it's quite early, and he has received. Let me just have a look again. So he just received on day 3, so just 3 days ago, dexamethasone. So I don't know what amount, but probably not enough to be already very immunocompromised regarding to this. But he had broad spectrum antibiotics, which is quite an important feature to then increase the risk to get a candidemia. And of course, he had a catheter. So I think here the 2 important risk factors that we have in our patients are the broad spectrum antibiotics and the catheter. Actually, the blood culture, it doesn't say, but was it drawn on a catheter line or a peripheral? Because then you can still, decide if it's what type of candidemia. But I assume it was on a catheter line. No.
No, it was interesting that this was on day 6, the blood culture result became available, but it was a blood culture taken just within 24 hours of the patient deteriorating. And it was taken really 24 hours after the antibiotics, the broad spectrum antibiotics had been started. So that's on day 6, we got the result, and it wasn't a tip, it was a proper blood culture bottle.
Okay, so peripheral blood culture from very early, so from day 2?
No, from day 3 or 4.
Okay.
3, 4.
There are two very nice questions in the chat. One from Lucas saying that this particular patient that has a sickle cell disease that usually suffers from autosplenectomy. Are they more prone to fungal infections as they are to some bacterial infections? So autosplenectomy make the patients more prone to fungal infections?
This is an interesting question. As far as I know, I would say no, but Martin or Garifale, have you read anything according to?
No, I also have not heard that they do. I mean, the candida likes to go in the spleen, obviously causing hepatorenal candidiasis, right? But I don't think it has been investigated on a bigger picture. And it may have also to do, in part at least, I mean, first of all, it just may not be the case, but it may have to do also in part that, you know, if you think about fungal infections, and especially low and middle income countries and Africa, there are many parts of the world where the research into fungal infections, also diagnostic capabilities to diagnose fungal infections, is just starting to evolve, right? So that's always something that we should keep in mind. I mean, of course, we do have patients with sickle cell anemia also in Europe and other parts of the world. But that's definitely something also to keep in mind when interpreting the current literature. But I'm not aware of something that's showing that this is a clear risk factor.
Well, I can add to this discussion. Textbook knowledge says that sickle cell patients are not profoundly immunocompromised, if immunocompromised at all. Actually, they are vulnerable to infections by pathogens that have a capsule, like meningococci, pneumococci, and so on. And in particular, there is no recommendation to be covered against fungal pathogens when they present with sepsis. There's no demonstrated vulnerability unless there are additional factors such as central lines and so on. In this case, I would like to make the devil's advocate, and I would ask Marlies if this patient received tocilizumab before being intubated. It could have inserted another risk factor for candidiasis. What do you think?
So the person did not receive tocilizumab, just received dexamethasone and remdesivir. But I'd like to add, and to Sarah's point, the blood culture was taken within 24 hours of starting broad spectrum antibiotics. So I think that's probably unlikely, but it was it was positive, or the blood cultures were taken after the first round of exchange transfusions. And that required a central line. So,
and there's also another interesting question from Anusha. I think Martin is addressing it, but it's concerning galactomannan and beta-D-glucan in terms of if it is helpful or not in guiding therapy in a way, because there's some new data on that in terms of this biomarker-guided therapy of invasive candidiasis.
Yeah, so I think it's a tricky question. I mean, theoretically, in this particular patient, who we know later on was diagnosed with candidemia, there is a chance that beta-D-glucan was positive earlier than the blood culture, right? So that's the one thing to tackle. So if we had beta-D-glucan in this particular patient earlier and started treatment based on that, we may have been a little bit earlier in terms of treatment. But there's, as you said, there's some literature that kind of like discourages us from using beta-D-glucan as a broad screening tool to initiate antifungal therapy, because if we screen our whole ICU population, we will find a lot of patients with a positive beta-D-glucan test, and only a proportion of them really have or will later develop candidemia. So that's basically why we should not use this indiscriminately, which does not say, if there's a certain patient where there's a stronger clinical suspicion that this patient may have candida infection, then beta-D-glucan is also helping for initiating antifungal therapy. But usually we like beta-D-glucan more for the opposite, which we like more for kind of like ruling out. If we decide to start a patient on antifungal therapy because we are clinically really suspecting candida infection, we should not delay treatment anyways, because time is money here and time is survival. So we would rather start, based on how we did this, for a long time now, based on our clinical suspicion, but then we would take beta-D-glucan beforehand. And especially if it's negative beta-D-glucan, we may be able to discontinue the antifungal early. So there it may save an antifungal and it may help us in terms of its negative predictive value. But we don't encourage using beta-D-glucan screening for starting an antifungal.
And if I may add something on this, just the fact that considering the anemia, he probably received a blood transfusion as well, and blood transfusion can cause false positive beta-D-glucan as well. So then it makes it a poor diagnostic tool in the ICU for this kind of patient.
There's also another question from the name is EGR. I don't know if it is this correct. I think concerning beta-D-glucan is addressed, but another question is concerning exchange transfusion. Does it affect immunity? Once we know that red blood cell transfusion had some impact on immunity, so exchange transfusion per se, could it be also a risk factor?
Transfusion itself not. The main thing is, of course, what leads to transfusion, which is anemia. And we can think of all sorts of, centralization of the circulation. Every centralization of the circulation leads to some extent of a leaky gut, right? So that's, I think, always important to keep in mind. So if a patient is very anemic or in septic shock or whatever, and every centralization, which means less blood flow through the gut, could lead to some extent, and the extent is different, of leaky gut. And that by itself may then lead to translocation of candida and also of candida cell wall components, which, explains why Sarah said, at least in addition explains, why we do have beta-D-glucan in these patients, because it's often going back to, that they're translocating, maybe not whole candida species, but cell wall components of candida, which are smaller, if the gut is only a little bit leaky. So yes, but of course, assuming all that, septic shock per se, definitely a risk factor for developing candidemia. And if there's a certain extent of centralization, it's always a risk that candida gets translocated from the gut, always also causing candidemia.
Yes, Garifali, I think you also want to make some comment.
I agree with the mechanism proposed by Martin. And I would comment further that, yes, plasma exchange can remove also immunoglobulins. However, one would not expect this from the very first course, from the very first day. It is one of the things that we are thinking of, particularly in patients with other situations who need regular plasma exchange courses.
Okay, I think great discussion. We can, I think, move on in the case. I think there's a couple of nice topics.
Okay, so the patient was treated for an presumed candidemia, which was then later confirmed. And as we've already said, the subsequent microbiology test confirmed Candida albicans. We followed the current recommendations, so all lines were changed. The person was seen by our ophthalmology colleagues, and they felt that the assessment was, they were not concerned about his eyes, his cornea and his retina. He had an echocardiogram, and it initially raised some concerns because there was the cordia looked a bit thickened, a lot of discussion, but this was reviewed twice in multidisciplinary cardiology clinics and MDTs, and it was felt not to be a vegetation, just some thickening of the cordia. So to come to the end, so the patient received 3 weeks of anidulafungin. There was always concern because he had ongoing fevers. He didn't really improve initially. He developed progressive acute kidney injury, needed high pressure ventilation, needed renal replacement therapy. His fevers prompted ongoing searches for underlying infections, so imaging, more blood cultures, more virus screens. And to summarize them, the imaging showed some improving changes in the lungs, but they also showed some deep-seated DVTs, which we didn't know about. So this meant that he had to be anticoagulated. And on day 14, we had evidence of CMV reactivation because he was still very febrile and so unwell. Ganciclovir was started, but this was not an easy decision because we wondered for a while whether it was significant or not, but in the end decided to treat with a course of ganciclovir. And this
may
is
I just stop here just because there are some questions. And this is quite an interesting question that I was already, I think, answered, but I think we should have an additional reinforcement of this, because Sonia asked if we have the same patient in septic shock that all screening comes back negative, so negative blood cultures, except for a positive tracheal aspirate with Candida albicans. And the question is, do you treat? And it will be dependent on the or it will be dependent on the clinical context. So the same patient, septic shock, negative blood cultures, but a positive tracheal aspirate with Candida albicans. Do you treat the patient with antifungal therapy or not? That's the question of Sonia. Can you just elaborate on that, please?
Yeah, I mean, I just jump in. I think it will depend on the patient, what other risk factors are present. I mean, obviously, this is a patient that we're seeing quite often in our ICUs, a patient that just gets worse in septic shock, right? And at one point, I think that's important maybe to emphasize, at one point towards the end of life, there will be a lot of translocation, right? At the end, we all translocate Candida through the gut and have very high beta-D-glucan levels. So we did at one point a study of beta-D-glucan in patients who were terminally ill. And we saw, even days before the patients actually died, beta-D-glucan was really increasing to crazy levels. So at the end, basically, our gut gets leaky, and the same is true in the ICU, obviously, which does not per se mean that the patient is dying because of Candida, right? And I think that's always important to consider here. But I agree, there are patients that are otherwise where we still have hope, basically, and we don't have any infection focus. And of course, we do have translocation at one point, and they're septic, which means they potentially translocate also Candida species, right? So in such patients, we might decide at one point to initiate an antifungal. I don't think that the tracheal aspirate by itself really informs this decision. I think it's a general decision that we make based on our patient, because everything is basically everything else is negative, and we are still hoping to save the patient. But I think this is exactly the patient where we would say, okay, we take a sample for beta-D-glucan test right before we start the antifungal, which is important because later on it's harder to interpret. But we take the sample and we start an echinocandin if this is something we would have done anyways, right? And then just based on the result of beta-D-glucan, we can reevaluate the patient. And generally, of course, we always need to reevaluate, not only using beta-D-glucan, but also all other findings that come in these patients with empirical treatment. Yeah, I think that's there's no clear yes or no, right? So it comes back to basically the individual patient. But I think the Candida albicans in tracheal aspirate is not helping us to inform this decision.
And another question, it's a little bit on the same side, could be for the other experts. And what about the Candida scores?
Yeah, I mean, go ahead, please.
Well, I was ready to comment on the previous question.
Yeah, okay, go ahead.
I would use this culture from the sputum as a surrogate of colonization of the mouth in order to use it in the Candida score. And the Candida score, I believe it is an important score to guide our clinical decisions. So I would never use the Candida sputum culture to cover for septic shock. However, the septic shock patient should be evaluated for the risk of having also candidemia.
Sarah, do you want to comment also on the question, the first question?
No, I agree with Martin and Garifelia here. I'm not going to add anything.
Okay, and there's another question. I think it's maybe also to you, Marlies, concerning the duration of therapy of the 3 weeks of a needle of fungin. It was why this duration?
That's a really good question. The person essentially continued to be febrile, and I bring this up on the next slide.
Okay.
And he could, maybe I show this now. So the person continued to be febrile with intermittent episodes of instability. The blood cultures always remained negative, but he was persistently beta-1,3-glucan positive. And in the absence of any other positive cultures and the absence of a clear focus, he had 3 weeks. This was also triggered a little bit by the fact that clinically we had some concern whether maybe these thrombi had got infected. We were unable to prove this, but this came up regularly as a discussion point. And on one scan, the bones looked, particularly the hip joint, looked quite abnormal, raising the possibility of bone infections. And so this is my final slide. This is where we are. We had a complicated case of, a patient with a complicated course of candidemia. We never really found the main trigger. It started after the exchange transfusion, which started within 24 hours of starting my broad spectrum antibiotics. Throughout the course, the patient has had ongoing fevers. There was a CMV reactivation, but apart from that, we never found any other bugs. And we have ongoing concerns about possible deep-seated infections. Finally, he's now at a point where he's making progress and rehabilitating and coming off the ventilator. But concern remains, that there may be infection, but the anidula fungus is stopped now. And at regular intervals, we have discussions why the person developed such a serious fungal infection when he wasn't that compromised beforehand. And I don't have the answer, but again, it would be really useful for me to hear the external view of international experts as they are on the call now.
So if I may start, like in this kind of cases, to help the ICU specialist, I would really dig into this because the only thing that you rely on, it seems at this point, is the beta-1,3-glucan levels. I would really dig into this, have a kinetic of all the sample that were performed, and see exactly when, like, is it a plateau of the beta-1,3-glucan? Was it what was the level exactly? Because and try to check with important false positive factor, like when did he receive again blood transfusion, or can I pair the going up and downs of beta-1,3-glucan with something, try to rule them out as false positive before really counting on them as a real indicator of something fungal going on. So that would be, yeah, what I would advise first. I would say as a clinical mycologist.
Can you go a little bit further concerning the kinetics of beta-D-glucan, because it's something I think important. When it is high,
I mean,
how long does it take to decrease again?
I mean, it can decrease. I mean, it depends how high it got also, because there's a limit of like the most used beta-D-glucan assay at the moment is probably the one that everybody uses. And there's a threshold of 500, and whenever it's above this, then the mycologist would just give you above 500. And these, in case of like when they're very high, they may often be in relation to IgIV, or like was Gary Fairley was saying. So if they didn't decrease at any point and they were all above this threshold all the time, I actually would, except for the cases of pneumocystosis, by experience, I would start like questioning them.
If I can
I fully agree with Sarah here. I think great. I think the one thing we have to be worried here is about, of course, the imaging suggestive of possible bone infection in this patient with the history, right? So, and I think that's also what Sarah wanted to, we would have to look into beta-D-glucan levels over time. If this patient really developed osteomyelitis, candida osteomyelitis, we would experience, and the patient is off antifungal treatment, so right, we would expect beta to increase basically and not, stays in the absence of antifungal treatment, because osteomyelitis usually, is progressing. It's not going away by itself. So, I mean, especially in this patient, I mean, it can, if there's another patient where we have the immune system coming back, etc., it may be different. But what we know from this patient, I would look into kinetics. So if we see that there's a trend toward beta-D-glucan, even if a continuous increase or something, I would be worried. But again, beta-D-glucan alone won't help us, right? So we need to go to where the money is, which is the bone, where the possible infection sits, basically, to really detect the organism, be sure we can't say it's albicans just because albicans was in blood culture, etc., right? So I think, it may help us a bit to guide further diagnostics. It may not help us with the diagnosis.
So just to add, the latest, the beta-1,3-glucan fell, and in the last 8 days, it's been negative.
Oh, yeah. So this, patient is getting better, getting out of the ICU, beta-D-glucan becomes negative. So that's definitely something we're seeing. So here in this patient, it may not indicate candida osteomyelitis. Yeah.
2 additional questions related to beta-D-glucan.
Can I comment also on this? Can I comment? Can I add a comment on this?
Of course. Yeah.
Well, I would also be very concerned about the increasing of the plateau values of beta-D-glucan, taking into account that the half-life is about 20 hours. And the suspicion of endovascular infection is very important. When it comes to bone infection, probably I would not expect a very high release of beta-D-glucan. However, in this scenario, I would like to think about the membrane that was used for the plasma exchange, because there are reports that these kind of filters may trigger beta-D-glucan, and possibly there could be a mechanism of false positive in that case, not clinically significant. However, if we have a bone infection, it is quite difficult to eradicate, and we should be well prepared for a surgical approach that would confirm also the diagnosis and would help to eradicate to a good amount the pathogen, and then go for a prolonged treatment with antifungals.
I think that this discussion on beta-glucan is quite interesting, and there's two additional questions. One from EGR, that is it the beta-glucan is affected by renal function and also by renal replacement therapy? And the other question is if can be false positive results related to some drugs.
I may just jump in, and others may have comments as well. In terms of renal therapy, renal replacement therapy, it depends on which kind of like dialysis we're using. But we did a study a few years ago, and state-of-the-art renal replacement therapy should not cause false positive beta-glucan levels by itself. However, the fact that patients need renal replacement therapy and the underlying disease could cause beta-glucan levels to be elevated. There's always going back towards the splanchnic perfusion, etc. That going back to beta-glucan, but it should not be the. I mean, at least we did a relatively large in vitro study where we used different techniques for renal replacement therapy, and we did not find an elevation of beta-glucan by that. But this doesn't mean that patients who need renal replacement therapy, that by itself, the underlying disease is something that would definitely could cause elevated beta-glucan.
And what about drugs?
We have this. I mean, others may have ideas. I mean, we've discussed a lot of drugs and about galactomannan, where this plays a big role. I mean, Sarah mentioned blood transfusions and CSF, GM-CSF that have been shown before that could cause false positive beta-glucan levels. So there might be some drugs, but it's not something, I think, apart from that, from those mentioned in terms of other drugs we're using in the ICU, like antibiotics or so, I'm not aware that a lot has been described. Although when you go back, I think it's always the issue when you go back to measuring beta-glucan actually in the blood, in the bags of the infusions, right? You can often detect beta-glucan to a certain extent. The question is how much is this a driver in the patient? And that's what I mean. There's lots of studies that basically looked into measuring beta-glucan levels in different drug preparations and found beta-glucan detectable, but the translation to the patient in terms of how much this does drive a systemic level is the one which is more questionable, because the concentrations are usually not that high in the drug. But there's exceptions like transfusion, colony stimulating, etc., that have been shown to cause actually false positive beta-glucan in a patient. And I think we talk about drugs, but the other big part is surgical gauzes, right? But that is not a drug, but surgical gauze definitely is known to cause positive beta-glucan levels in patients. Yeah.
Any other comment? There's Anna that is asking what about piperacillin tazobactam, because I think has been a concern for a while.
Yes, this was a concern, but rather with the galactomannan testing and not beta-glucan. And they have now switched their way of purifying the drugs, so that normally has not been any problems since a few years now.
Okay.
Pedro, we've got about 30 minutes left, not less. We have another interesting case.
Yeah.
Should we just discuss the second case, because the second case will also stimulate discussion about related topics. But
agree.
So if I stop and then take a handover to Martin.
Great. Should I share from my screen?
Yeah.
Okay.
I mean, ultimately, these are cases, they're all patients with life-threatening fungal infections, and the focus is on why do some patients become so ill and their life is at risk from fungal infections, and others tolerate fungal infections easily.
So let me just go to full screen mode.
Great.
Okay. So I will walk through a few cases, and I hope I don't have to cough too much. Basically of COVID-associated fungal infections, but to make this more interested, COVID was not the only predisposing disease in some of these cases, although we heard, of course, during the course and also in the presentations by Agostino Carvalho and me, that COVID by itself can be enough for patients to develop, particularly aspergillosis, or in some cases also mucormycosis. So let's start with a case that at the end turned out to be not aspergillosis. Basically, this was a patient, 53 years old. He had a previous medical history of an AML, which was secondary to an MDS, and was diagnosed 3 months prior and treated with, induction chemotherapy, 7+3, classical regimen of cytarabine and daunorubicin. He was obese with a body mass index of 34. And in terms of clinical presentations, 5 weeks after induction chemotherapy, the patient presented with a sore throat, paresthesia, and dysomnia and fever up to 39 degrees. So this whole case happened in early 2020. So I think it was April or May 2020. So of course, with these symptoms back then, there was a strong clinical suspicion that this patient had actually COVID. Patient has been severe neutropenic for 8 weeks. Oxygen saturation was 96%, and the chest CT then showed slight bilateral infiltrates and ground glass opacities. Because of his neutropenia, the patient was receiving antifungal prophylaxis with voriconazole, and therapeutic drug monitoring showed levels that were within the target range for prophylaxis. So of course, at that time, and you have to remember at that time, we thought that, fungal infections may occur in COVID-19 patients. And of course, the patient also had underlying risk factors for fungal infection. But back then, we really only worried about COVID, of course. So that was our primary focus. So we did a PCR test for SARS-CoV-2, which was positive. He was still neutropenic at that time point. And unfortunately, the patient got worse, which happened rather often back then, developed moderate acute respiratory distress syndrome with an OI of 115 and was admitted to the ICU first for non-invasive ventilation. So we were lucky, our ICUs were not so full that time, so we could admit patients for non-invasive ventilation, also because our respiratory care units were also full with patients with non-invasive ventilations. And then treatment was initiated with tocilizumab and high-dose glucocorticoids. Back then, before the dexamethasone studies, starting with prednisolone, and then continuously tapering basically over 17 days. So unfortunately, the patient was not doing better. He was getting worse during the ICU. So his ARDS got worse. On the 8th, his chest imaging chest X-ray got worse. He had an OI of 60 on the 8th, and he had to be intubated on the 8th after symptom onset on the 3 of the ICU. At that time point, we performed bronchoscopy and BL, which I think was something rather good at this time point, because many other institutions did not really do a lot of bronchoscopies in COVID-19 patients. But in our institution, they did it if it was necessary, like in this patient. And it was also something that we insisted. And in the meantime, of course, it has been shown to be relatively safe, also in COVID-19 patients without the risk of transmission, especially if you're using a closed loop. So in terms of diagnostic workup, the BL galactomannan was negative, the BL culture was negative. Also serial serum galactomannan tests were performed, also because of the underlying disease of the patients that were all negative. Serum beta-D-glucan was positive only once. All other results were negative, which is also an indicator, potential one, a one-time elevated serum beta-D-glucan that could be a false positive, of course. And the neutrophil count increased, luckily, from day 16 onwards, above the threshold of 0.5. Of course, this patient received antibacterial therapy, like probably too many patients did with COVID-19, with piperacin, tazobactam plus linezolid, but of course, very much in line with having neutropenic fever. So that remember, this patient doesn't have only COVID, but also had neutropenic fever. And there is, of course, a clear indication for broad spectrum antibiotic treatment. However, we just decided to continue voriconazole because we thought the levels are in the target range. And we did not think of another fungus that could be voriconazole resistant in this patient playing a role here. So the patient improved slightly, was extubated on day 18. So with regards to COVID, the patient was getting better. But shortly afterwards, he developed again fever up to 39.5 degrees Celsius. We again did a number of tests, blood cultures, but also looked for venous catheter infection, viral PCR tests, and fungal biomarkers. All were negative. And of course, if you look back and see where this patient developed at that time point, we could have made things different in retrospect. And unfortunately, we did not have a lot of time because the patient showed rapid respiratory deterioration, was reintubated on day 22. SARS-CoV-2 was still positive. Also, BL unfortunately did not grow anything of relevance. And the hemodynamic situation unfortunately worsened. And the patient passed away 2 days later after being reintubated. So we also have to say thanks here to our pathologists who heroically, during the early stage phases of COVID-19, agreed to do an autopsy in this patient, a full autopsy, which was done, I think, too rarely. I mean, many did this, minimal autopsies with, targeted needle aspiration or, but I think they did a full autopsy, and with that, they looked into lung tissue, and via microscopy, they could show tissue invasive growth of a non-pigmented fungal hyphae and necrotic lung tissue. So clearly evidence for a proven pulmonary fungal infection, and the pathogen, the causative pathogen, was identified as Rhizopus microsporus. Unfortunately, this all happened after the patient passed away. Consequently, of course, we diagnosed this patient with a proven infection by Rhizopus microsporus. And if you look into the cycle threshold, of course, we also did PCR test for SARS-CoV-2, but the cycle threshold of 28. So taking everything together, it is rather likely that also the mucormycosis contributed to the fatal outcome in this patient. So the key learning points here for us, and I don't want to focus only on COVID here, but focus basically on mold infections in the ICU more in general, that not everything we are seeing is Aspergillus. Most mold infections we are seeing in the ICU, most pulmonary mold infections are Aspergillosis, but there are also some other molds, like, for example, Mucorales, that can cause pulmonary mold infections, particularly in patients that have other risk factors, other immunosuppressions, underlying hem-onc malignancies, etc. So that's always something that we should keep in mind. And voriconazole has no activity against mucormycosis, for example. So we need another antifungal agent like Ambisome or isovuconazole or posaconazole to have activity against mucormycosis. Generally, talking about mucormycosis, of course, worldwide, we're seeing a lot of cases of renal-orbit or cerebral mucormycosis, like we've seen with the black fungus pandemic in India. But in Europe, but also in the US, more than 50% of cases are pulmonary mucormycosis cases that then later on get disseminated. So it's definitely something to keep our eyes out for and think about if we suspect a fungal infection but have negative biomarkers. Unfortunately, culture is not very sensitive for diagnosing mucormycosis. So as in this patient, that can also stay negative. And before I go to the next two cases, which are very short, let's open this up for discussion, I think.
Thank you very much, Martin. It was very good. Again, the webinar is focused on underlying pathophysiological processes and and susceptibility and risk factors. And I just wondered whether maybe you or one of the other experts here also could just briefly summarize where you think the key reasons why this patient developed an invasive fungal infection related to the underlying pathophysiology. Yeah, thank you.
So here we really have the case of a patient deeply immunocompromised. I mean, on top of neutropenia, which is a major risk factor for invasive fungal infections, so this patient received corticosteroids, which so we explained that will have an effect both on the neutrophils and on the macrophages that are remaining in this patient. They will prevent phagolysosome killing, and they will prevent also ROS production from the macrophages and the neutrophil, which are major mechanism, antifungal mechanism. This patient also received anti-IL-6, right? Tocilizumab, Martin, I think. And this is another important risk factor, which will also have an effect on the leftovers neutrophil by preventing degranulation and also preventing ROS production that are aimed at decreasing the cytokine storm in this patient, but can have side effects. So clearly, this patient really had a very, very deep immunocompromission of his immune system. So yeah, this is and of course the voriconazole was preventing aspergillosis, but as Martin said, it was not efficient on mucorales, so that's probably why he developed mucormycosis.
Yeah,
do you want to add anything to the risk profile and susceptibility?
I think Sarah did an awesome job as always. I mean, obviously the patient also had COVID. I mean, maybe that's something to add. So the epithelial disruption of the lung tissue may have made it easier for mucorales to grow basically from the lung into the tissue. We can hypothesize that, maybe the voriconazole changed the respiratory microbiome to leave more room for mucorales to grow there first. But that's, pure speculation and but not there yet. But that may have played a role there as well. But definitely, cytokine storm may have contributed. But I agree with Sarah. The patient was heavily immunocompromised even without COVID-19. So at the end, I would say, in this patient, the underlying disease and treatment may have been even more contributing factor with, maybe COVID adding a little bit on top. But I agree with Sarah in terms of outlining the most important mechanisms that contributed here.
Thalia, did you want to add anything?
I totally agree. He has multiple risk factors, and the predominant is the underlying neutropenia and the underlying hematological malignancy as well. Nothing further.
Can I ask Martin, what could we have done to identify this? So we always learn with these clinical cases. In the future, what would be your different approach in this situation?
Yeah, so I think, obviously we had for a long time, and we still have kind of like limited diagnostic tools for diagnosing mucormycosis. So at that time point with this patient, doing a lung biopsy would not be really, something that was likely to be done. So that's, of course, retrospectively you can be smarter, but prospectively, it's not something that's likely. But I think what we have now, for mucormycosis, apart from histology, for a long time we had to rely solely on BL culture, right? And there is some advances now that there are now commercial PCR assays available that can be tested from BL, but also can be tested from blood. So that's definitely something, if now we had such a patient, we would potentially also order, in addition, where everything is negative, we would say, okay, from the remaining material, do a mucorales PCR, right? So that's definitely something we would look into, and also send blood samples from mucorales PCR. I think these tests are available and they should work rather good, but we still need a little bit more data to really identify the clear position of this PCR in the diagnostic algorithm, namely whether they should be performed right away with galactomannan, or rather in big cases like this one where we don't find a solution from the tests we perform first. So I think all of this needs to be determined. So the clinical benefit of doing the PCR on a large scale also needs to be determined. But that's definitely now something that's different from where we were, this 4 or 5 years ago, where at least in my institution, we did not have access to mucorales, to, CE certified mucorales PCR.
If I may add something to bounce on Martin's comment, we do in our institute have the mucorales PCR, which is usually done in case of any kind of suspicion for invasive fungal infection, parallel on the same multiplex with Asperger's, and it has helped a lot. Not on a certain type of patient, we have a huge ICU burn unit in my hospital, and it has been started to actually screen the patients with the mucorales PCR. I mean, severely burned patients are at risk for invasive mucormycosis as well as aspergillosis. And since they are screened and we get actually positive PCR much earlier than on a sample, and they've been treated. I mean, they've been treated, the patients, on a positive two positive mucorales PCR on a row, and they've tremendously decreased the number of of really severe mucormycosis case in the ICU burn units.
It's an interesting, thank you, it's very helpful. It's an interesting question here, and relates to your lecture. So in your lectures, which are available online, you outlined that fungi get entry into the host through the skin or the mucosa. Is there anything we can do to protect and reduce the risk? Is there anything we can do to protect the skin or the mucosa from being invaded?
I mean, yeah.
Go ahead, Sarah.
Go ahead. I mean, it's difficult. I mean, you have I'm talking about severely burned patient with more than 20% body surface burn. So, I mean, there are kind of lotions and things that you put, but it's not really proven. I mean, on a like clinical trial basis, but no, I mean, really, and for I mean the air mucosa and the lung mucosa, I mean, we're using antifungal prophylaxis, but nothing has been on the market otherwise, right?
So I think the question relates to general critically ill patient, not just burn patients.
I mean, just going to the gut, obviously, if we can find something, to prevent the leaky gut, right? That would have, strong implications, not only on fungal infections and bacterial infections, but, a much broader field of medicine where, microbial translocation, persistent inflammation, etc., play a role. So obviously, there's lots of interest in that. But unfortunately, as Sarah said, I mean, there's also a number of clinical trials, for example, looking into statins, etc., but nothing really breaking through. Some of these trials come from the HIV field, actually, where also this, low-level microbial translocation, persistent inflammation does play a big role in, making people with HIV, although virally suppressed, getting ill or dying earlier than others do. So there's definitely, a good amount of interest and money going to that, but unfortunately, I think we don't have anything yet ready for prime time that we really use in clinical routine. But definitely also would be interested in seeing what others think here about that.
There's two questions. I think one is related to the chest CT, if there is any particular pattern of the mucor lesions in the chest CT. And the other is a little bit of the discussion that you had, Martin, before concerning the patient if we should have started or not, unfortunately, be at that stage. That one is more, yeah. So go ahead.
So the first one, so let's start off with the last one, with the ambisome. I mean, of course, retrospectively, yes. I think at this time we should have thought about this. We could also discuss whether to start, at least. But usually, if we have a voriconazole and want to switch, we want to switch drug class and not stay within the same class. But that said, there would even be an argument to switch, if we can't start for some reason liposomal amphotericin B, to switch here from Bosa to Isavo, or from voriconazole to isavuconazole or bosaconazole, because they have broader coverage that goes beyond aspergillus more than voriconazole. So I think, retrospectively, yes, that would have been. We would have also done it if it wasn't a patient with COVID at the time point, right? So we kind of explained lots of his worsening with COVID. So that was kind of the issue we had back then. But of course, if it's a regular hem malignancy patient, with infection, we don't know what it is, getting worse and worry, we would kind of change it. But it was just not with the second infection on so much on our focus. But yeah, it would have made sense. I fully agree, to broaden the antifungal coverage there. And going back, sorry, can you repeat the first question, Pedro?
Was patterns of the chest CT concerning mucor.
Yeah, I mean, patterns of the chest CT, I mean, usually CT really helps for diagnosing mucor, especially non-COVID patients. So what we often see is the reverse halo sign, for example, in chest CT. But of course, we are seeing this with COVID as well. So, right. So with COVID, we did have the problem that, a sign that we are often seeing with mucormycosis is a sign that we're also seeing with COVID-19, with severe COVID-19. So in COVID-19 patients, it was harder. We did have, I think, I'm aware of another patient with mucormycosis we had who also had a reverse halo sign, but it was the same problem, that we did not know, does it come from mucor or does it come from COVID? So yeah, so I think that's an issue. I don't know if Sarah wants to talk more on that.
No, I think you've covered the topic well.
Okay, so we are here for more than 1.5 hours. I think this has been a very, very good discussion. We unfortunately we could not go through all the questions, but I think if they email to the office, the experts would be more than happy to address them. There are a couple of them that I was not able to ask you. And so Marlies, do you want just to also give some words on this?
Yeah, thank you. I mean, I enjoyed it very much. And I think these cases and our discussion highlight what you also said in your presentations online, that this is an evolving field where things are still happening, where we learn new things, new technologies help us exploring the issue. But despite all of that, there are situations and scenarios which we don't fully understand, and where we rely on experts like you and our clinical expertise. So an evolving field. It's great that Gilead gave us this grant to explore this in more detail and develop this great learning educational program. And thank you to the experts for making yourself available for these discussions and sharing your expertise.
And also thank you for the participants for the questions they raised, quite interesting. And again, just is going a little bit from the bench to the bedside. I think we covered lots of interesting topics, and I want to thank the experts for all the excellent inputs they gave to us. Thank you very much. Bye-bye.
And we'll do this again in a month's time.
Yeah. Bye-bye.
Bye-bye.